Hi, Rob and Bob here with you in Marina Del Rey on a Tuesday night. And my dad was just at the Cervical Spine Research Society meeting in New York City last week and gave a great talk on athletes returning to sports after neck injuries and after neck surgery. And such a great topic. We love talking about it all the time that I figured we'd share it with you and see if you guys are interested in learning anything. And so how'd the talk go?
Talk went very well.
Yeah.
I thought it was well received, and I got across the points that I wanted to. But it's a situation that everybody in the audience had been in at various levels of competition. And so, these ideas of return to play are important, obviously, to the patient and to everyone concerned.
Yeah, they're right there. Mm-hmm. And this is a small group. The other people that are at the meeting are other spine surgeons we know from New York and Dallas and all over
the world. Yeah.
Right, and we all have the same decisions. And the great thing about getting together in meetings is we talk about it. Man, we had this tough case, and here's what we thought. And usually we'll get consulted on with multiple different people about different cases. So it's a pretty small crowd that makes these decisions. They're pretty tough to make, aren't they?
They sure are. I know you and I, over the last decade, have discussed thousands of cases and given opinions about athletes, non-athletes, and everyone else, from top professionals to high school kids and everything else. So it's important, whether it's the mom sitting there or who it is. It's sometimes a very, very important thing. And I think when I was first asked to do this return to play in athletes, I'm like going, who are we talking about here, and what sport are we talking about, and what type of injury? And they just gave me the shotgun type of thing. So I thought back over the top professional athletes that I've taken care of and we've taken care of together over the years, to thousands of adolescents that have similar type of injuries. And so who is the person is a critical thing to delineate. And it's not, a high school kid that parents and coaches think he's going to be the next world beater. Well, it isn't always true, and you've got to put that in perspective as a 15-year-old.
Yeah.
The other thing is what sports. So when we looked at this, we broke down the sports roughly into collision, contact, and repetition sports. We made it up for the talk. I don't know if anyone's quite classified it like that, and there's some overlap in certain sports. There was a gymnast paralyzed last month, so it varies from sport to sport. And the repetition people, when I was the main consultant on the PGA Tour, lower back led the hit rate. I mean, that was that was so common to have those types of problems. There's a lot of neck motion in golf and under stress too.
Yeah.
So collision sports, especially the head contact sports, where there's axial loading from the top of the head down, and it's kind of like a soda straw. If you squeeze both ends of it, it buckles in the middle. And that's when you really get injuries in the cervical spine. So
in collision sports, we're talking about football, American football, rugby, hockey, and wrestling, MMA. Those are all collision sports.
Yeah.
And then the one next safer category would be a contact sport, which would be baseball, basketball, soccer, lacrosse. And those sports are tough because generally they're pretty safe, but they always have the potential for a bad head contact that could be a spinal cord injury type of situation.
Yeah, I had a third baseman, Major League Baseball third baseman, look up for a pop fly. While he was looking at the pop fly, became temporarily paralyzed due to his stenosis. So it comes in. We've had a basketball player that we operate on that set a pick in the NBA and got run over and had a temporary spinal cord injury. So it comes in all types of varieties. We had one of the MMA guys the other day, and I said, well, if you get dropped on your head, it could be really serious. He goes, I won't.
Yeah,
I had a top all-pro cornerback one time, had a bad x-ray and bad MRI, and I said, well, if you hit somebody with your head, it could be real trouble. And he looked at me and goes, okay, I won't.
Yeah, I won't do that, right.
He's all pro.
And the importance of that is if you're 28, 30 years old, all pro, and know your position and know how to avoid certain things, that's different than an 18-year-old kid playing defensive back, undersized, trying to make the team.
Yeah,
they're going to have to hit people with their head to be able to survive, or at least they're more prone to. And so that's part of the decision making is who is it, what's their age, are they getting paid, is it a professional sport or not? Is part of it. Is what's the age, what's the sport? So is it collision? Is it a contact, more of the basketball, baseball variety? Is it high velocity, which is gymnastics? What's another high velocity? skiing, water skiing,
All
snow
water
skiing, you know, the potential for that. And then the fourth category that you came up with was repetitive.
Yeah.
Is it like swimming, where you're turning your head 50 times every minute? It would be its own special type of risk injury pattern.
And it's golf. Like I said, in golf, professional golf, a lot of neck injuries. There's a lot of neck motion in golf, and you have to account for that. I think the type of injuries that people get, the burns and stingers, is a pinched nerve in your neck where the pain and numbness and lack of function goes down your arm. That may be due to foraminal stenosis, which is a narrowing of the hole the nerve goes out of. That's been well documented as a cause. Herniated disc in your neck, that happens in all kinds of sports for all kinds of reasons. A fracture. We had a water polo player, collegiate level water polo player the other day, that's making a shot on goal, gets his arm blocked, no head contact, and gets a lateral mass fracture in his neck, which is a significant fracture normally due to head loading type of contact. So they come in all shapes and varieties. And just a sprained neck, you know, like all of us may have had at times, whiplash type, head gets popped back and have stiffness and pain in the neck. But herniated disc fractures, and one thing we always say to shorten it down, if a player comes off the field, especially in football, and has a stiff, painful neck that wasn't stiff before that play, it's a broken neck until proven otherwise. Drew Dossett was at the meeting and made the point of asking a football player in the middle of a game, does he have pain? You don't always get an accurate answer. And you've got to know the examination. And this head pressure and head motion and a newly stiff neck is a big deal in competitive athletics at the scene of the event, because things are a lot of adrenaline, a lot of pumped up kids, and they don't always feel pain the same way they normally would. So the criteria, as Drew covered in that part of his talk, was that return to play during an event. Look what's changed with concussions. You don't send anybody back that was knocked out, where in the past that did occur. Well, now, no, you don't. Anybody that has any memory loss or any evidence of loss of consciousness does not go back into that event, and is taken out of the event into a private area for an examination. Well, necks are much the same way. You can't go back if you hurt your neck. You can't go back unless you're pain-free, with a full range of motion, no numbness and weakness in your arms, neurologically intact, and this resistive, where you can press on the head, resist that, resist this, and have no pain in the neck at all. So that's the immediate criteria. A lot of our decisions are made down the line, where there's been an injury, the patient's referred to us, not during the event, but referred to us later for a consultation about should he return to the sport to practice or anything else in the sport. And that comes in these varieties of lateral mass fracture, disc herniation, foraminal stenosis, burn, stinger. And then we bring in the cases of people that have surgery that we've operated on or other people have operated on. And the operations basically come into two varieties. One from the front, which is an anterior cervical fusion, the usual treatment for a disc herniation, or an artificial disc replacement. Those are the two main ones from the front. And in the back, you go in and you open up the hole the nerve goes out of, which is called a microscopic foraminotomy. We don't do in competitive athletes, we don't take out disc herniations from the back. And part of this posterior foraminotomy operation, the microforaminotomy operation, comes in a lot of different varieties. And it mainly boils down to how much bone are you going to take off and how aggressive are you going to be. If you're going to take out a fragment and you've got a nerve between you and the fragment, you're going to take off more bone. The man that trained me, Robert Warren Williams in Las Vegas, had a very meticulous, small, detach the ligament, undershave the portion of the joint, but never enter the joint type of foraminotomy. Well, you're less likely to get subsequent problems. There's one review that said that half of the posterior cervical things in contact sports of posterior cervical operations fail at that initial level due to head contact. Well, that depends on a lot of different factors. It can be an effective approach to a problem depending on the problem. But
and we certainly do that surgery in hockey players, football players, baseball players, a foraminotomy in the back. But it's more for stenosis and other issues if they've got active nerve irritability with testing, but you don't have to go take a big piece of disc out.
Yeah.
The discs are in the front, so going in the front to take the disc out from the front is a safer, more reliable surgery, and it generally entails a fusion. And I'll just mention our study that we did on fusions in professional athletes, because we reported more than anybody ever has. There's 25 of them. 80% made it back to play after a single level neck fusion. 80% return to play. The average return was 9 months. So if somebody's going to go back and get paid $5 million a year to do their job for the next 3 to 5 years, it's the most reliable surgery to get people back to their job, to be able to work.
That's right. With the posterior disc removals, we've seen 2 fractures and 1 recurrent herniation referred to us. There weren't cases we did, but that's an important differentiation. Differentiation. The artificial disc replacement is becoming a more and more popular operation. So far, we've never recommended that in a collision sport.
When we actually have.
No, you're right.
Right.
I forgot.
We got 2.
Yeah.
The one was an NFL kicker, but he was a kicker, and we told him, look,
don't hit anybody.
if you're the last person standing, you're not allowed to tackle the person in your head. And he said, same thing, fine, I won't.
Yeah.
The other one was an MMA fighter,
yeah.
but he was towards the end of his career, and he really just wanted to fight a couple more times, and he had multi-level disease, so if we fused it, there was a higher chance he'd have problems from the other levels, so doing an artificial disc preserving motion made sense, and he had triceps weakness. We were able to take out the herniation through the artificial disc. But that's more precarious because the preservation of motion, the implant can loosen and develop problems, whereas the fusion, you're not worried about it.
Yeah.
And so, there is always some gray zone of sometimes they're willing to, and it's complex decisions. Just what you mentioned before is what we look at is who's the person, how old are they, what's the job, what's the position, what's the risk for contact, what exact surgery you're doing.
And that was one of the ones where we said, well, don't get dropped on your head. And he goes, I won't.
Yeah, exactly.
I mean,
okay.
Okay. All
right.
Yeah, he's a top professional. He had many fights. So that also varies. When you're dealing with younger, inexperienced athletes, it's a different type decision than the all-pro cornerback. And how do you come back? I mean, after these fusions, we typically at 6 months have an everyone in the room meeting where everybody meets. We look at the CT scan. Is it healed? Is the patient well? Has he been through his conditioning program? And we try to document numerically whether this guy's in shape and can avoid injury. What's your best way to avoid injury when you return? Be in the top physical condition of your life and be at the top of your sport. So if you go back too soon, you're not going to fulfill those criteria and you're more likely to get hurt because that's where your breathing is. You get a fracture there, you stop breathing, you may be dead on the field. So, once you get into that area, and we've had some fusions in that area, one real prominent case, someone else did the fusion, I certainly would never clear him to return to the NFL. And so occiput tattoo is a whole different, dangerous, if you will, area. Harry Farfan, the man who wrote Biomechanics of the Spine, was a personal friend of mine and cautioned very strongly about any operation from C3 up because it may deleteriously affect the biomechanics of the occiput tattoo. And we've had odontoid fractures, we've had torn transverse ligaments, we've had we've had C1 ring fractures, we've had all these in pro football players.
Yeah.
So they occur.
Calcifications of the ligament of flavum, indenting up at C1, C2. We had 2 of those in 1 year.
Yeah, symptomatic,
Right.
causing spinal cord symptoms. So that area is a really difficult area to make prognostications about. If you're doing anything that affects that, that's going to by and large exclude you from a collision sport. And the contact, you just have to watch it. We've had a football player that had congenital abnormalities where they're born with a fused skull to C1 and things like that. And we had one of those in a pro football player that because this congenital fusion and abnormal wear pattern, even though the symptoms weren't that bad, I just couldn't see clearing him to return to contact. And I watch some of these defensive nose tackles. I mean, they stick their head in there sometimes, and a guy's just trying to take his head off. So. Right. It's just a really difficult situation with these congenital abnormalities. So every congenital abnormality, all of us involved in this look very, very closely at that. Do every test we can to try to know exactly what's going on with some abnormality somebody's born with.
And what about preventative? Do you think that doing rehab and building up muscle strength actually helps protect the neck?
Absolutely do. The problem is that doing neck strengthening exercises like pushing against your head or moving weight with your head produces some wear and tear osteoarthritis in your neck. So if the problem is osteoarthritis in your neck, using that as a solution is not always a wise thing to do. But yes, if you have, for example, you're born with a narrow spinal canal. We have one NFL guy now that we're working with about, because if you get an episode of temporary paralysis called transitory quadriparesis, you hit somebody with your head, you have a narrow spinal canal to begin with, and you are temporarily paralyzed. Well, we start with how paralyzed was he? What were the findings? How long did it last? I've had one kid that had 1/3 the normal size spinal canal, one man, I'm sorry, 1/3 the normal size. He had a 5 mm spinal canal, had a 15-minute episode, and we can't let him go back to play. If you have somebody with a 15 mm canal and he was paralyzed for a day, we're not going to let him go back to play because something's wrong in the vascularity of his core. We may not know what. So you got to go, how bad an injury did he have? How severe was it? And then work backwards. What are the anatomic findings in his spinal canal on all of the tests? Don't spare any test. And someone that's had a spinal cord problem and you're trying to tell them whether they should continue on a sport, get all the CT, SPECT scans, MRIs, everything you need, all the measurements you need in order to make a decision about that.
Ultimately, what we're looking for the risk assessment is, what's the chance you can go back and play your sport effectively? What's the chance you'll have a neurologic injury if you go back and play? What's the chance you'll have issues for the rest of your life after you finish playing? You're only 25 years old. You're going to end up to your 80.
That's important.
What's the chance of having future problems? And so those are all the things that we look at and we consider when going into these things.
Yeah. No, I think all those things are important. So this conditioning thing, yes, you can get big and strong with really strong neck muscles and traps and everything, and it may be less likely you'll hurt your neck. There's a price to pay to getting there. And then the other thing is for the doctor, this is saying, Frank Jobe, one of my partners early in my career, emphasized the rehab. If you can't control the rehab, don't do the surgery. And that's been part of the mantra we have. And so we have an excellent, in the Back Doctor app, we have an excellent cervical rehabilitation program. Second thing is, in making these decisions to these athletes, the person making the decision has to know 100% making the decision based on what's best for his patient. Not a player, not one of the members of the team that you're the big fan of. That's crazy.
Don't worry about trying to win the World Series. Think about that person.
Right. No. That's your patient, and treat them like your patient. What's the best thing for them? And you know what your patient's job is. If he works in a meat packing company and it hurts his back, you got to know what his job is. You got to know what he's got to do to go back to the job. It's the same thing as an athlete. You've got to have an understanding of the sport. That's why going to the games, watching the practices, understanding the mechanics of what your patient has to do is an important element in making these decisions. So you talk about, people have talked about, well, does the doctor work for the team? I don't, too much into that. The doctor's there to take care of the patient. And that's the key thing in these circumstances. And my colleagues in this field, I guarantee you they're interested in the patient. There's no question about that. And they know what they ask the patient, what do you want to do? I've had patients walk in and say, I just want to be able to play with my kids when I retire. Well, that's not somebody that's the goal in life is smashing somebody in the next football game. So, you have to know your patient. What does your patient want to do? And it's a key part of the decision.
And one of the greatest things about our job being a doctor is it's a win-win. If the patient does well, we do well, and so we're on the same page by definition, which is great, and obviously makes things a lot more easy. I'll post a couple podcasts we've made about artificial disc versus fusion versus foraminotomy, and even a laminoplasty versus fusion. I'll post those if you guys are interested in more info.
I didn't mention that.
Yeah, and so I appreciate you sharing what you spilled out in New York and everything you got out of that.
Yeah, it was a good meeting.
Yeah, and thanks for joining us. Hope you guys have a happy Thanksgiving. And if you have any questions, type them at the bottom, and we'll be sure to respond.
Yeah,
thanks
happy holidays.
Bye.
Thank you.